Thank you so much for your attention, for being here, for allowing me to show you some of the interesting work from our laboratory. What I'm going to mostly show you is not research, it's clinical cases. So I am a medical director in a reference laboratory at the University of Utah, ARUP Laboratories. And one of the challenges that we've had, of course, is that sometimes it is recognized that a genetic test is wanted after a sample has already been fixed in formalin. And this prevents some of the traditional testing that we would have liked to have done. And there have been advances, though, recently that allow you to really now look at the whole genome in these FFPE specimens to gather information that was previously either not of good enough quality to really want to be using it in a clinical diagnostic realm or just wasn't available. So I wanted to share with you some of the data that we've been collecting using a particular platform and how it's compared to some of our traditional fish-based assays and how it complements some of the sequencing assays. So first of all, this is a really fairly recent paper that came out in Nature Genetics looking at the results from the TCGA study where they profiled 12 different tumors and really showed that tumors aren't just driven by one type of mutation. Of course, an oncogene doesn't care exactly how it gets turned on, it just needs to get turned on, but that there are certain tumors that are much more likely to have somatic mutations and other tumors that are much more likely to have copy number mutations. And so if you're not looking for both classes, you're going to miss the whole profile. And some of the cancers that were in some cases almost exclusively driven by copy number changes include the 4 that I've listed here: ovarian, breast, lung squamous, and head and neck. And so this really sort of drove home the point that you need to be looking for both copy number and somatic mutations. This is another recent paper that had a similar point. This is from Foundation Medicine, looking at, again, a large number of cases, and these are all of the different genes that they were looking at for actionable alterations. And you can see over here in this pie chart what type of alterations did they find. And you can see that actually if you look at both the amplification, deletion cohort and compare it to the mutation hotspot, that there were more copy number alterations that were actionable for these patients than just somatic mutations. So when we think, okay, well, we need to identify copy number changes, we know they're important. What are the options out there? It's been traditionally done by FISH. And our laboratory certainly has been doing FISH for quite some time in FFPE, but we know that it has a high failure rate. And so there are times, even after trying multiple times, that we have to issue a report that's inconclusive, which is, of course, frustrating for the clinician and the patient. There can be the false positives and false negatives, mostly due to the fact that you have to truncate, we have to slice the paraffin, which can truncate nuclei, and so then you have to use control loci in order to determine whether or not you're looking at a truncated nucleus or not. But the control loci can sometimes introduce a false result, and we'll show some data about that. And also having to have control loci limits the number of loci that you can even look at, because you may only care about one region, but if it's a copy number, then you need to make sure you have an intact cell, so then you have to include another region on the same chromosome and do a ratio of the two. And so now you've used up 2 fluorochromes for one question, and there are only so many fluorochromes that you can use with FISH, so then it also really limits the number of different questions you can ask in a single assay. For a while, people have been using array CGH. One of the more common platforms would be Agilent. However, this has a fairly high DNA input requirement, which can be difficult to achieve with some tumor biopsies. The heterozygosity detection is not very crisp, and that's also, of course, very important in cancer specimens to have really good loss of heterozygosity information as well as copy number information, and does not perform as well in the mosaic cancer calls as some of the data I'll show you today. People have been also looking at using next generation targeted sequencing for copy number. This is also, of course, challenged by this poor quality DNA. If you have very poor quality DNA, then you can actually get false positive amplifications because you're having a bias in your sequence capture and your read depth just from the quality of the DNA. And it can be difficult to determine exact copy numbers with this technology, and high sequence depth is required, as well as careful selection of normals. So what I wanted to talk to you today is a technology known as molecular inversion probes. It's been in the literature for a little while. It was initially developed as a genotyping assay, but then was recognized that it could have great capacity as both a genotyping assay and as a copy number detection tool. So the probe itself, and you can have hundreds of thousands of these probes in an assay, but the probe itself has a fairly simple design. So it initially is a linear probe where there are two regions that are going to be homologous to a region of the genome. So it needs a 20 base pair footprint here and here, and that will be homologous to a sequence in your DNA, in your patient's DNA. And then when those two regions hybridize, there'll be a particular region, this is your SNP of interest that you're going to genotype, that will get filled in through gap fill, and then there will be a ligation so that now this is a circular probe. Because you only need 40 base pairs of homologous sequence in order to have this specific hybridization and therefore then the subsequent padlocked probe, you can use really highly degraded DNA because you only need that small sequence to be intact. After you've created the circular probe, you then use exonuclease digestion to get rid of all of your FFPE poor quality DNA. So you're getting rid of your poor quality DNA fairly early in the assay, which then can prevent it from mucking up the assay later. After getting rid of any unused probe and any FFPE DNA, then you have a particular place here where there's a cleavage site that then creates two PCR primer sites so that you can amplify now your tags, and then you can use a spot here to hybridize those to an array. And by hybridizing those to an array, you can now get essentially a count of how many of these padlock probes did you form, and that count can tell you essentially the copy number of the sequence here, and then it can also tell you the genotype of that particular SNP site of interest. So you can, since you're not amplifying genomic DNA directly, you do not introduce the bias that is seen in some assays. Because you only need that 40 base pair sequence, you can really use it on very degraded DNA, and you get very clean data, as I'll show you, and can do very accurate copy number detection. So the kit that we've been using recently is known as Oncoscan. The way that it's designed, it has 220,000 of these probes, and they are spread throughout the genome. However, there are some regions that have higher density of probes than others. So this has been primarily thought to be useful for FFPE, and most samples in FFPE are cancer specimens. So there's been a focus on 900 cancer genes, where you can see that across these 900 cancer genes, we're getting resolution of probes down to around the so this is the density of the probes, and then this would be the resolution because of you have sufficient number of probes in a region this size to be sure to detect an alteration of that size. So there's quite a few genes that you could detect down to levels that are lower than what you can do with FISH right now. And then across the whole genome, because of the coverage across the whole genome, you're at around a resolution between 300 and 400 kb, which is also getting down to the resolution of FISH, but now throughout the entire genome. And then because of determining the SNP, the genotype of interest, you can look for genome-wide loss of heterozygosity patterns. In addition, it was recognized that there are some somatic mutations that are recurrent that could be detected using this technology because of that, looking for that specific SNP of interest, you could build in some specific somatic mutations. And so there are 74 different mutations that are built in, spread across these genes, as you can see here. The sensitivity for detecting these mutations is at around 20%. I also wanted to briefly mention the utility of looking at both the alleles as well as the copy number. So the way that the software allows you to look at the alleles is in two different ways, and I appreciate looking at it in both ways. One is to look at the B allele frequency. So since you're a diploid organism, you're going to be either AA, AB, or BB at any particular SNP. And so if you are normal across your genome, you expect a sort of equivalent distribution of genotypes where you're AA, genotypes where you're AB, and genotypes where you're BB. And so if you were to plot your B allele frequency, again, you would have some that have no B because you're AA, and so you would have some plots at 0. You would have some that plot at 50% because you're AB, so 50% of your genotype is B, and you would have some that plot at 100% because you're BB, so you have 100% B allele frequency. Then if you had a deletion in a region, you should have only one allele. So you should have either the A allele or the B allele and have a B allele frequency of either 0 or 1. If you have a duplication, then you should have a pattern that is here at 100% BBB, but then this represents BBA at about 66%, AAB, and AAA. So you can see that the allele pattern changes with your dosing, and so it can be an independent confirmation of your dosing, not just having to look at just the amount of probe that hybridized, but also looking at the allele information directly. You can also detect then this copy neutral regions of homozygosity or loss of heterozygosity. It's called different things in the literature, but this is where the pattern is very similar to deletion, so you would use it in combination with your copy number log-2 ratio to determine that you had absence of heterozygosity. As mentioned, there's another way to look at this data within the same software, and that's just looking at A minus B, allele difference. It's also called allele peaks. And so these are the patterns that you would expect if you were just to determine the A minus B for a deletion, a normal, a duplication, and a copy neutral region of homozygosity. And one of the things that I like about this pattern is that the copy neutral region of homozygosity looks different than the deletion because we're also having changes of the outer bands as we have losses and gains. All right, so what does this look like on the software? So here is the log-2 ratio for a sample that has a gain of this chromosome region. So you can see that obviously it's elevated, and then you can also see the pattern that we expect on our B allele frequency, with some being at 100%, some being at about 66%, 33%, 0%. And then here's for a loss. You can see obviously the log-2 ratio is decreased for this region of this chromosome, and then we have no alleles coming in at 50% because we're either 100% A or 100% B. All right, so at ARUP Laboratories, which is where I act as a medical director, we're using Oncoscan on a number of cases, and this was just some of our initial evaluation because we thought, okay, we think of it as probably a good replacement for the FISH assays initially that continue to fail in our laboratory. And so what are we repeatedly doing FISH on, and where we would have value in having an alternative technology? And we do 1p19q deletions and EGFR amplifications in gliomas. This is a very common request. We do MDM2 amplification in lipomas, NMYC amplification in neuroblastomas, and HER2 amplification in breast. So that was sort of our starting point, but we also know that there are many other copy number alterations that can be relevant in these tumor types that we may be also able to assess with the single assay. In our initial evaluation, we did not do any microdissection, macrodissection. We just went with estimating what the tumor burden was in the sample and then seeing how the assay performed. And our tumor burdens ranged from 40 to 90%, and all of those worked really well. We've been able to go down to around 20% tumor burden and still get good quality results where we can see copy number changes, but we feel that that's kind of where the limitation is, that as you get below 20% tumor burden, you start to lose sensitivity for some of the changes that you would need to detect. So what we now do is we have an H&E slide, and then we determine if there is any macrodissection necessary to do tumor enrichment prior to DNA extraction. This is taken from a recent, well, it's not that recent, 2011, but I think a really nice review from the Archives of Pathology and Laboratory Medicine about the different pathways of molecular changes that sort of define the different categories according to the World Health Organization for gliomas. And you can see, I didn't make this up, it's mostly things that you could detect by copy number, and then just two mutations here, an IDH and P53, and everything else is a copy number alteration. And so what you could clearly see is that there would be a value if you had a single test that could look for these different alterations if gliomas was one of the sample types that you commonly saw in your laboratory. So we focused initially on some gliomas, and here's a case that was 1p19q deleted by FISH, and it was also 1p19q deleted by the Oncoscan. It's really clear, so you can see the log-2 ratio decreased, and you can see the B allele frequency pattern changed for a homozygous deletion. For a mosaic deletion, not it's heterozygous and it's mosaic, for 1p and 19q, and the rest of the genome is really quiet. And I sometimes, hear people say, well, I like my FISH assay because I just have a single question and I get a single answer and it's not going to be too complicated. I tell you, for these 1p, 19q gliomas, they are not terribly complicated. They'll have some more changes than this occasionally, but for the most part, they don't have a lot of genetic changes, and this can just be a really quick and easy assay to read out as well. As I mentioned, there are some mutations built into Oncoscan. IDH, the common mutation in IDH1 and 2 is included. This is seen in, it's pretty much seen in any glioma that has a 1p19q deletion. And so we also picked up this deletion in these 1p19q deleted cases. So this is a positive control that's put into the assay. These are all the samples that were negative, and then these are the individual cases that have both the IDH1 mutation and a 1p19q deletion. All right, here's a second case that was a little bit of a conundrum for the laboratory. The physician initially just went through the normal ordering patterns. We hadn't launched Oncoscan yet, and they just ordered 1p19q because it was a glioma, and that was negative, and then they ordered EGFR because it was a glioma, and that was negative, and then they felt a little bit confused at that point because there's not a lot more on our menu for them to consider. We offered Oncoscan, and one of the things I'm just first pointing out, of course, is that the FISH was correct about 1p and 19q and EGFR. We also don't see any deletions at 9p and chromosome 10, which are commonly altered. But we do see right here, chromosome 17 has a normal copy number, but it has a copy neutral loss of heterozygosity of 17p that is mosaic. And so that was a big clue in this case. And as I mentioned, there are some mutations that are built into this assay, and some mutations in p53. So we looked at the mutation data as well, and it does have the IDH1 mutation that would be consistent with it being a glioma, but it also has a p53 mutation. And so that 17p copy neutral loss of heterozygosity is now selecting for that mutated p53. So we're able to, in one assay, confirm this, and knock out these findings and give very specific information about the grading of this tumor. I wanted to show you an EGFR amplified case to just show you how nicely those stand out. So here is EGFR amplification. You'd only miss it if your eyes were closed. You can also clearly see a few other interesting findings. For example, the P16 CDKN2 homozygous deletion, which is very common in the primary glioblastomas, as well as P10 loss, which is often due to whole chromosome 10 loss. So this is all very consistent with a primary glioblastoma. There's, again, not a lot else that we really have to get into. There is a focal 1p deletion, and I wanted to point this out too because the size of a 1p deletion matters. When you have whole arm 1p19q deletions, that's a good prognosis. When you have these focal isolated 1p deletions, they're much more likely to be associated with a glioblastoma and a poor prognosis. So that's the other thing I like about this assay versus FISH, is that you not only know that there's a 1p deletion, you know its beginning and end points. And so this is just to show how we would classify this case, that we were able to eliminate this possibility, identify all 4 of those, and classify it as it's a poor prognosis. All right, we've also looked at this in the context of HER2 FISH. So certainly when HER2 FISH is positive, you would expect this to be positive, and here's a case where they were consistent. You can see the amplification of HER2 right there on chromosome 17q. Sometimes clinicians will ask questions about things beyond just HER2. For example, the topoisomerase 2A gene is here. If amplified, then patients may respond to topoisomerase inhibitors. So since it's nearby HER2, it's often co-amplified. But if you don't check, you don't know. And so by using a whole genome assay rather than a specific FISH, we can determine, in this case, HER2 is amplified without co-amplification of TOP2A, whereas in this other case, HER2 is amplified and TOP2A is also amplified into an even greater degree. So it's another option for treatment. We also had some discordant cases. I think everybody who's doing IHC in fish will have some discordant cases for HER2, and there's a few good biological reasons for that, and you can see that sometimes in these arrays. So here's a case where fish was positive and again, fish is done as a ratio. You're comparing the ratio of HER2 to a chromosome 17 centromere probe. However, that probe is a little bit kind of on the P arm, and you'll see why that's important. Anyways, when it was looked, it was called out positive by fish, but when we did the array, we don't see anything on 17. It's not elevated. We don't see a spike right there. When we look closer at this chromosome, what I hope you can appreciate is that 17q has a normal copy number and 17p has a mosaic deletion. So it's the control probe that is being deleted rather than the probe of interest that's being gained. And when you do things as a ratio, having your control probe deleted will make it look like your region of interest is gained. And so this was a false positive fish result. And it was clear what was going on when you did the array and you knew that it was 17p that was deleted. Here's another example where fish was equivocal. So they reflexed to a qPCR and called out the qPCR as positive, but we put it on an array and we're a little concerned because again, there is no spike that we see here on chromosome 17. There are some other spikes that may be interesting, so there certainly are alterations in this cancer that may be of clinical utility. But what's going on 17? It's actually a mosaic monosomy. 17 across the whole chromosome has a mosaic loss. So here in blue are the probes around HER2, and you can see that they're slightly lowered, and you can see here with the B allele frequency that this is a mosaic deletion. And so this is not a gain. And again, just doing qPCR sometimes with ratios can also, especially when you're comparing it to in a genome that has lots of copy number alterations, can give you a false positive. We're not the only ones that have seen this. This is a paper published a few years ago, also showing that when you have 17p deletions or monosomy 17, it can result in false positive FISH results for HER2. And so in that paper, they suggested an algorithm where immunohistochemistry and FISH are initially done, but if there is a discordant between these results, then an array in all of their cases has resolved the issue and has shown the biological reason for the discordance and has allowed them to be confident in the classification. Another area in which we've had requests for this type of assay is in melanoma. This is, at least in the US, for every melanoma that is removed, 30 benign nevi are also removed, and that's because it's the surgeon sort of, if in doubt, cut it out. And I don't disagree with that theory, except sometimes the mole is in a very conspicuous place, and and 2 centimeter margins is what they try to go for, can be rather disfiguring. And so there have been requests that maybe we could do a better job of classifying some of these melanocytic lesions of unknown clinical potential with a smaller biopsy material before deciding whether or not to do a more radical recision. So there's historic literature using array CGH with 1 microgram of DNA showing that there are consistent patterns of gains and losses in melanomas, whereas nevi are relatively quiet. And so that maybe looking for copy number alterations across the genome could be a way of determining the genomic instability of the sample and therefore the likelihood that it represents a melanoma. This is work that we published a couple years ago looking at Oncoscan and looking at benign nevi, atypical lesions, primary melanomas, and metastatic melanomas, showing that these samples worked very well on this assay and that the MIP array did a very nice job of reproducing the historical data and classifying these samples. So this is the historical data using 1 microgram of DNA, and this is our data using 80 nanograms of DNA. In fact, we had one specimen with only 15 nanograms of DNA, and we proceeded with it, and it also yielded good quality results. And so one of the things I wanted to compare it to, as I mentioned, was FISH. There is a panel out there called Melanocyte. It's produced by Abbott Molecular, and it looks for alterations really at just 3 regions. And again, this comes back to this idea that when you do FISH, you only have a couple regions of the genome that you can target. But they felt that with the recurrent changes, that if you targeted these 3 regions of the genome for gains and losses, you could pick up about 70% of melanomas and distinguish them from benign. But 70% is not that great. The problem is that in order to get better sensitivity, they'd need to add more loci to the panel, but they run out of fluorochromes. So we just asked the question, okay, if we had been running just the FISH assay on our cases, how many of them would have had abnormalities that hit these FISH probes? And in our series, 6 of our 27 positive cases had abnormalities throughout the genome, but didn't hit where these 3 FISH probes were located. So they would have been normal for those 3 probes. Here's just an example of one of them. So we can clearly see this deletion here, deletion here, deletion here, gain there. This deletion here does hit 6q, which is where one of the probes are located in the melanocyte assay, but unfortunately that probe is 15 megabases away from the deleted region, so it's in a normal regions of the genome, even though there is a nearby large 6q deletion. All right, so now we've launched this. It's available through our clinical lab, and we're also using it now in some pilot clinical trial studies with our Huntsman Cancer Research Institute. So we've enrolled relapsed cancer patients. The initial idea was to just even see if the clinicians changed anything after having results from these whole genome sequences. It started out as an idea of let's look at mutations using the sequenome panel. And then it was recognized that we should be adding copy number because of the publications that have been coming out. And so we've added now Oncoscan to 48 of these samples. Looking at the results from the first 137 that were run on the sequenome panel, we have approximately 35% of them have a mutation. And so that's good. We're having something that we can return to the clinician on about 35% of the cases. But what about this? What does the copy number add? So here's some examples. Here is a metastatic colorectal tumor. It does have a KRAS mutation, but that's expected because of the diagnosis and not necessarily helpful at this point of relapse. However, we do see an amplification of CCND1, and that can be targeted. Here is a metastatic melanoma. Sequenome found no mutations, but clearly there's an amplification here also involving CCND1 that can be targeted. Here's a metastatic colorectal tumor. Again, not surprisingly, it has a KRAS mutation, but it also, now we know, has an amplification of CDK6, which can be targeted for therapies. Here's a lung adenocarcinoma, a sequenome, no mutations, but you can clearly see copy number changes. The one that I want to highlight is right here. It's actually not so much a copy number change. It's a change in copy number within the ROS1 gene. So inside the ROS1 gene, and that's why you really want this high density coverage so you can see exactly where that breakpoint occurs. You can see that inside the ROS1 gene you go from a gain to a loss. It's highly suggesting that there's been a translocation within that gene, and ROS1 translocations are well understood to be occurring across a series, including lung cancers, and represent options for therapy. In fact, just looking at the NCBI's listing of open clinical trials, we found 4, actually one's not yet recruiting, so 3 recruiting studies for patients that have ROS1 alterations. Here's a lung adenocarcinoma with no mutations by sequenome. I'm pointing to this peak right here. There's a few, but this one really, we look at everything. This one really, though, easily stands out. And what is that? That's an FGFR1 amplification. That can be targeted. Here's a lung adenocarcinoma with no mutations. We can see that there's lots of copy number alterations. We look at this again for what's actionable. So we know the patient has cancer. They've relapsed. They're probably going to have multiple changes. But what of here can we target today? We can target their MET amplification and their HER2 amplification. Here's a sample. It wasn't part of our study, but they heard about it, and they were, this is a patient from Yale. They were kind of thinking what to do now because this patient had gone through a number of things. At first, I have to admit, I opened up this case and I went, oh, there's a lot to go through. But again, we know that the patient has a sarcoma. We're not trying to decide whether or not they have a sarcoma. We're just trying to say what's actionable. So you can keep track of currently what's known to be actionable, and you can go looking at those regions. And so I hope that you don't miss this, but there's obviously a really amplified region, focal region right here on chromosome 4, and that includes PDGFR alpha and KIT. And so it is likely that this patient could respond to either imatinib or sorafenib. We've launched this not just for oncology specimens, but we've launched this for FFPE specimens, and one of the utilities that has come out was the pediatric pathologist calling us and saying, hey, we'd like to be doing copy number on some of the autopsy cases where it wasn't recognized at the time of the autopsy that there could be a genomic syndrome that's probably like it looks like aneuploidy. It wasn't recognized at the time, so we don't have any fresh tissue, but we do have now FFPE tissue. Can you do anything with it? And so, and sometimes these thoughts come to the pediatric pathologist even later. It may be after multiple losses, and now they want to study some of the early losses, or it may even be just a really good clinical geneticist, and that's the story I've got here, a really good clinical geneticist who remembers patients for 15 plus years, and then when a new technology comes out, calls you and says, hey, I'd like to resolve this issue. So this is one of those stories was a local geneticist who described 2 children back in the literature in 1994 as having this sequence of findings, and then in his own reading of the literature about this microdeletion syndrome on 21, thought, wow, that microdeletion syndrome looks a lot like what those 2 girls had that I published back in 1994. I wonder if they had that microdeletion syndrome. And so he went trying to find out where are these 2 girls now. It turns out one of them was deceased, and an autopsy had been done at the local hospital. And so he contacted and got specimens from the autopsy, and we ran it on the assay, and he was right. She had a 21q microdeletion syndrome, and we were able to diagnose it from 20-year-old FFPE. The last thing I wanted to mention was this idea of also why you want to have good allelic performance. So we mentioned that it detects loss of heterozygosity, and that can clue you into a mutation that's being selected, but it also can be really important for determining the correct ploidy of a sample, and this can be challenging, particularly solid tumors love to just double their genome and then go on their merry way of having genomic alterations. And so you need to understand the ploidy of a tissue in order to sometimes really understand the genetic alterations. So here's a case where if you just did the assay as required and put in the amount of DNA as required, you would have this pattern for your log-2 ratio, but you would also notice when you looked at your allelic pattern for A minus B or B allele frequency that there's a problem. So for example, I have a pattern here for A minus B and for B allele frequency that is normal, and yet it looks as though I have a gain of chromosome 4. So that's a flag that something is different about the ploidy of this tumor. Here's another area of concern. This indicates a high-level mosaic loss, and although there is a loss of this chromosome, the log-2 ratio is coming in only at around 0.4 rather than around 0.7, as I would expect. So by looking at this, I know that my genome needs to be shifted down, that I have a hypodiploid. Not a hyperdiploid, but a hypodiploid genome. And so I can correct within the software and say, okay, chromosome 4 is what is normal diploid, and I know that from its allele patterns, and then after doing that correction, it becomes clear that this particular kidney tumor is hypodiploid with the following losses, and that is consistent with a chromophobe renal tumor, which is a poor prognostic finding and is associated with hypodiploidy with loss of these chromosomes. So recognizing that loss would have been hard if I wasn't able to determine the correct ploidy, and that's why you need really good allele performance. So I'd just like to acknowledge members of the team. These are directors and collaborators that we've worked with, and then we have a large laboratory at ARUP. Affymetrix, the manufacturer of this technology, and Biodiscovery, the makers of the software that we've been using to look at this technology, and is also available through Affymetrix. I'd like to take any questions if you have them.